thank you very much indeed for another fantastic talk to Professor Kim. We have time for a few questions, most of which I'll remind you to put them through the Q&A box that appears at the bottom of your screen. And I'll pose the first one to Patrick, if I may. So this question from Dr. Markumians relates to the head impulse test, or the Halmagyi maneuver. And the comment really is, how useful is it in real life? Because it is frequently inconclusive, because people commonly find it very difficult to fixate gaze. So how reliable do you find that as a test?
Well, that's a very good question, Stefan. And indeed, the Halmagyi is not easy, but it's helpful. So the two issues are that sometimes these patients still have a lot of nystagmus, especially in brainstem and cerebellar strokes, pica, and in peripheral vestibular disease. And then because they have a lot of nystagmus, it's very difficult to judge whether their Halmagyi is positive. So this test is really much more helpful if there is only very little nystagmus, or sometimes severe dizziness, but no nystagmus at all. And secondly, as in my patient I've shown you with the video, it's not always that easy. So it's sometimes very subtle, and sometimes it's even better to send the patient to neuro-ophthalmology or neuro-otology. And the third thing, is it 100% specific? Of course not. There's no single symptom or sign, especially in acute vestibular syndromes, that is 100% specific and sensitive. So as always, you have to combine everything, history and all multiple symptoms and signs, before you come to a conclusion.
Thank you for that. Can we, another question I'll direct to Jong, if I could. A comment from Dr. Pradhan: can a small occipital infarct be associated with ataxia? And if so, why might that occur?
I don't think a small occipital infarct can produce ataxia. Maybe if a lesion involves a parietal area, then maybe they may have some positional sensory loss on the contralateral limb. That may manifest as ataxia. Or if the lesion also involves the thalamus, then it can, maybe thalamus may not be visible on MRI, I guess. Then it could may explain the ataxia. Occipital lobe lesion, small lesion alone, I don't think that will produce ataxia.
There was a question that came in through the chat, which is another one which relates to the symptoms. And maybe Patrick, you could take this. You commented on the various ways of distinguishing central from peripheral symptoms, but as the chat comment points out, patients with acute vestibular neuritis have a great deal of difficulty moving or standing, let alone walking. So assessment of the motor features is very challenging.
So it's true that, of course, if you have severe acute peripheral vertigo, that you will have a lot of problems standing and walking too. But if the patient didn't have pre-existing gait problems, these patients usually, even they can walk. Of course, they can walk with either holding on to the walls or with somebody beside them. However, if you have somebody who cannot even get up with help, then you have to assume it's a brainstem stroke. So it's rather the opposite way. So if somebody cannot walk at all anymore, you assume it's a brainstem stroke. Of course, occasionally, then finally we'll still have to diagnose a peripheral problem. But it is really a very strong sign that patients have brainstem strokes. Can be both lower brainstem, pica, Wallenberg, or it can be upper brainstem, can be midbrain, with or without thalamus, which can give you a complete astasia or even impossibility to walk, and people have to crawl on all four extremities.
There are several questions that are linked to the use of MRI, and I'll maybe just try and pull those all together into one question, which I'll direct to Jong, if I may. So how do you approach people with transient symptoms where the MRI may or may not show an abnormality? And related to that, what about the timing of MRI in posterior fossa stroke? Is it important to undertake imaging at a particular interval after the onset of symptoms?
Yes, as Patrick said, some patients have some symptoms not very well distinguished between peripheral and central. Some examination are usually not very specific. So if you have suspicion, especially the patient have risk factors or aged, then I usually order MRI. The earlier the better, because the earlier we see the patient's lesion and pathogenesis, then the earlier we can give them appropriate management. But unfortunately, if it is done very early, sometimes it is missing. So if you really think there are a very strong possibility for some stroke, then you have to do it again. Usually routine MRI may miss some very tiny lesion in the medulla or pons. So sometimes we use some MRI with a shorter interval between cuts. And we only by repeated MRI, some lesions are identified. So I think if it is suspicious, repeat MRI may be a good option for them.
Possibly linked to that, how commonly do you misdiagnose Bell's palsy?
It's a very difficult question because when I see Bell's palsy patients, I usually do not order MRI. The case I presented is very exceptional. So I think if they have some high risk factors for vascular disease, such as long-standing hypertension, DM, you may order MRI, but everybody thinks that it is too costly because the majority are still peripheral. Actually, I don't have. Maybe in Switzerland, you are a very rich country, so you may order MRI for every cases. But Korea, it is not true for us.
I agree with you, Young. I think we're a rich country because we don't spend too much money on MRIs and we keep it on the bank. So.
Yeah, I think I'm conscious that we'll have to wrap things up fairly shortly. I think of the several other questions that have come through, thank you for everybody's participation. The question about thrombolysis has come up on a couple of occasions, and are there any differences or special considerations in use of thrombolysis in patients with posterior circulation stroke?
Well, I think there are 2 or 3 important points. One of them is that, in fact, bleeding in the posterior fossa after thrombolysis is clearly less frequent than in the anterior. And the simple reason for that is that the posterior fossa lesions are less large. They have less volume and therefore they bleed less. So bleeding risk should not be much of a concern if you respect the usual contraindications. Number 2, yes, the NHSS does under-evaluate the posterior fossa. So in my center, we usually consider the presence of a handicapping deficit as sufficient to do thrombolysis. And this does mean in the posterior circulation, if a patient cannot stand or walk anymore, that basically can be enough. And occasionally, you know that such patients can have an NHSS of 0 or maybe just 1 point, cannot walk anymore because of severe vertigo, and then we thrombolyze them. So I think you should stick to the usual criteria, which is if the patient has a significant handicap and this doesn't have any contraindication, is hopefully within short time windows, then it's important to do thrombolysis.
So thank you very much indeed with that. I think there are a number of questions that are all related to very specific symptoms and experiences, which I think probably are addressed in the body of the presentations. I think my impression is pretty much any symptom can arise from strokes in the posterior circulation, I think might be a summary. Other than that, I think we'll have all the talks are available online, Alina, I believe.
Yes.
And if my colleagues have the opportunity to type in any answers, they're able to do so. I'll thank both speakers for excellent presentations, and thank you for the opportunity to moderate. And thank you to the 400 plus participants from all over the world. I've seen people offering greetings from Bhutan, Nigeria, Portugal, all corners of the globe. It's fantastic to see that.